Welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to be spoon-fed the latest and greatest of emergency medicine. Our team combs through the literature for the best articles so that you don't have to, and provides expert summaries no bigger than a spoonful so that you can keep up with the ever-changing landscape of acute care medicine. This is the audio version of the past week summaries, all of which were brought to you this week by the heroic Clay Smith. The first article for this week was titled Liberal or Conservative Oxygen Therapy for Acute Respiratory Distress Syndrome out of the New England Journal of Medicine. In contrast to the days of old, we now well know that oxygen is very, very good, but too much oxygen is bad. Many large and well-done studies have shown this quite clearly. On the other hand, it's not a revolution that, of course, hypoxia is also bad. So if Goldilocks was strolling through your ER, where would she settle on an O2 saturation? Let's have a look at what this study has to say about that. This was a multi-centered RCT enrolling 205 patients with ARDS, who were split into two groups. A conservative group with a target SpO2 of 88 to 92%, and a liberal group who were targeting greater than 96% oxygen saturation. If you're already up to date on this kind of literature, you probably won't be too surprised to hear that this study was actually halted early by a data safety monitoring board because there was reason to believe that the conservative group had a higher mortality. For the primary outcome of 28-day mortality, at the time that they stopped the trial, the conservative group actually had an increase in mortality of 7.8%. So that was 26% in the liberal group and 34% in the conservative group. At 90 days, the disparity nearly doubled to a 14% gap. Again, non-significant. On top of that, 5 conservative patients developed mesenteric ischemia, as well as a possible signal that they may have had higher rates of arrhythmia, atrial fibrillation, and other complications. So what can we say from this? What we can definitely say is that it looks like an SpO2 of 88 to 92 is too low. But a nice study that we actually covered on the journal feed from October of 2019 showed that a range from 94 to 98% was a good target. Maybe we should stick with that. In a spoonful, when comparing the oxygen saturation target of 88 to 92% against a more liberal strategy of over 96%, the conservative group appeared to increase mortality in patients with ARDS. Other sources seem to have found that a range from 94 to 98% might be a good target, though. On to the next article, which was titled The Effect of Cefepime on Neurotoxicity Development in Critically Ill Adults with Renal Dysfunction, out of the journal Chest. Neurotoxicity. What is apparently a known side effect of cefepime, a well-known antibiotic, with neurotoxicity which is attributed to its ability to cross the blood-brain barrier, where it appears to show GABA antagonism, and this may lead to symptoms including depressed consciousness, encephalopathy, aphasia, myoclonus, seizures, and even coma. So who might be more at risk of seeing this complication? This was a retrospective review of 200 critically ill patients with impaired renal function who received cefepime. The overall incidence of neurotoxicity as a result of cefepime in this group was 6.5%. And although there was no statistical difference, there was a numerical difference between giving high and low doses, with 10% at the high dose group and 4% in the low dose group. There were just 5 patients in the high dose group who had severe renal dysfunction. There were more cases of neurotoxicity in this group with severe renal dysfunction. 0% of the patients in the low dose group, but this ended up making up 16% of the patients in the high dose group. But still, this also was not statistically significant, and likely due to the small numbers in the study. So, in a spoonful, although the signal is weak, patients with severe renal dysfunction receiving high-dose cefepime may have higher risk of cefepime-associated neurotoxicity. The third and fourth articles for this week are going to be kind of a point-counterpoint like we like to do sometimes in the journal feed, and we'll start with the 4-point. So, the third article was titled, Should the Use of Diagnostic Point-of-Care Ultrasound, that's POCUS, in Patient Care Require Hospital Privileging and Credentialing? Yes, out of the journal Chest. All right, just from the title, we're going to need to cover some definitions real quick. Credentialing is the process of obtaining, verifying, and assessing the qualifications of a practitioner to provide care or services in a healthcare organization. Privileging, on the other hand, is the process of authorizing a specific scope of practice for patient care based on credentials and performance. So to put them together, it's essentially a formal training system and then a structure within which to use that training. Emergency medicine and anesthesia have such systems in place in the United States, while critical care medicine does not. These authors argue that this red tape is required because incompetence with POCUS could lead to incorrect clinical decisions based on poorly obtained images and just misinterpretations. This is, of course, potentially dangerous to our patients. They point out that 50% of critical care fellowships do not have formal POCUS training curriculums. They go on to point out that instead, that if it was standard for all critical care training programs to meet a certain standard, then institutions could actually forgo privileging because the training programs would be sufficient as a proxy for competency. Since this is lacking, however, the authors advocate for a formal privileging system in institutions, and competence must then be proven. So in a spoonful, since critical care medicine programs do not have explicit training requirements or standards for POCUS, these authors think that an institution should provide competence through credentialing and privileging. Now on to the fourth article, kind of the counterpoint. This article was titled, "Should the use of diagnostic point-of-care ultrasound in patient care require hospital privileging and credentialing?" No. Also out of the journal chest. We try not to be too one-sided here at the JournalFeed, so here's the counterpoint to the previous article, essentially the argument against credentialing and privileging POCUS. The authors of this paper sought to weigh in on whether or not POCUS should be treated as one of those special skills that would fall outside the core set of critical care privileges that would also then require specific oversight and regulation. So they actually consider POCUS to be just another one of the standard diagnostic and therapeutic procedures within the discipline of critical care medicine. Procedures that already require special privileging are things like tracheostomies, burr holes, rigid bronchoscopy, and balloon pump replacement. These are all invasive, risky procedures that require a special skill set. Whereas POCUS is non-invasive, and multiple studies have shown that intensivists with minimal training are able to acquire and interpret images. These same physicians also tend to know when formal assessment is required and to order more imaging if needed. As it becomes more accessible, many are coming to think of POCUS as simply an extension of the physical exam. These authors go on to note that while not all, but most critical care education curriculums include POCUS, and most have extensive POCUS experience from residency, they believe that additional regulation would probably do more harm than good, as it provides the potential to strip this tool from the hands of clinicians at the bedside. Also, just to keep in mind is that decisions like this set precedents and may affect how we institute technologies that we've yet to invent. In a spoonful, these authors, in contrast to the last article, think that POCUS should not require special institutional credentialing and privileging because it is non-invasive, easy to learn, and at least nearly ubiquitous in residency and critical care training. All right, and on to the last article for this week, which was titled "Screening for QT Prolongation in the Emergency Department. Is There a Better Rule of Thumb?" out of the Western Journal for Emergency Medicine. Hey, this is the first podcast on an EKG paper, so listen closely. The widely taught rule to spot a long QT is using the half the R to R distance as a rough estimate of whether or not the QT is too long. Prior studies of this method usually show us that eyeballing it quickly doesn't really stand up very well against proper formal QT formulas. So, is there a better way to do this quickly? The authors compared a number of QT and half RR pairs. Their findings were that for elevated and normal heart rates, that the half R to R rule was actually more conservative than QT formulas, which makes it a good screening tool. With bradycardia, on the other hand, the half R to R rule performed poorly. As a fix for this, though, you can look for an uncorrected QT above 485 milliseconds in bradycardic patients instead. In a spoonful, for heart rates that are above 60 beats per minute, the half R to R rule we already know is actually a good conservative screening tool that can be used safely. For heart rates below 60 beats per minute, consider substituting in a 485 millisecond cutoff instead of using this rule. What did we learn today? Well, everyone loves a good O2 set target, but we have to know where to shoot. 88 to 92 appears to be too low. But there's reason to believe that 94 to 98% would be a nice place to be. Next, consider being careful with your cefepime dosages when dealing with patients with severe renal failure. Neurotoxicity is a risk and may be more common in this group. Next up, we talked about 2 articles which talked about the need for credentialing and privileging POCUS in the critical care medicine setting. One side said that it's dangerous not to standardize and is afraid of mistakes. The other side points out that POCUS isn't that tough and that experience is almost ubiquitous. What do you think? Lastly, we'd hate to deprive you of a quick and dirty EKG trick. And luckily, we don't have to. For heart rates above 60 beats per minute, the half R to R rule for spotting long QT is a good screening tool. For lower heart rates, consider a cutoff of 485 milliseconds. That might be a better go. Links to all the articles summarized can be found at JournalFeed.org, where, if you haven't already, you may subscribe and get our newsletter daily in your email, which is the best way to reinforce everything you've learned, to listen to the podcast, and to read the newsletters. To everyone who's going through this fraught time right now, I wish you well. Stay healthy, wash your hands, and I wish you the best of luck, one spoonful at a time.